dear colleagues, good morning. Thank you for the organizing committee for inviting me. It's a bit difficult to talk after Dr. Raed with his entertaining cases, but today I'm going to speak about PVC-induced cardiomyopathy. I have no conflict of interest related to this presentation. This is a little bit busy slide. These are my objectives when I'm going to talk about PVC-induced cardiomyopathy. We know that it was benign. Is there any evidence behind that? And the effect of PVCs on the mechanical function of the heart, the hemodynamic effects, risk of LV dysfunction. If there is development of cardiomyopathy, is this reversible or non-reversible cardiomyopathy? And the effect of PVCs in patients with non-ischemic cardiomyopathy and in ischemic cardiomyopathy, and what the guidelines tell us to do. We'll start with a short case. This is a 56-year-old female patient. She's known to have diabetes and hypertension. She complained of atypical chest pain. For that reason, she was admitted to the hospital. She denies any dyspnea or palpitation, and she had never had syncope before. Coronary angiogram was done and showed normal coronaries. Her echocardiogram at that admission showed normal ejection fraction and normal function of the heart. In 2014, during follow-up, echocardiogram was done and showed again ejection fraction still within the normal limits. In 2015, the patient was diagnosed to have non-ischemic cardiomyopathy and was found to have ejection fraction of 30%. She was referred to our EP clinic for implantation of an ICD. This is her ECG in the clinic, which showed sinus rhythm without significant ST or T changes or any new Q waves that indicates that there is ischemia or anything, and she's known to have normal coronaries 2 years ago. But what is significant that this patient had on this ECG 2 premature ventricular contractions, and these 2 PVCs are important to notice that they have negative deflection in AVR and AVL. The axis is inferior, and most importantly, the transition is late between V4 and V5. This is characteristic for something. For that reason, this patient was referred for Holter monitor, and the Holter monitor, not surprisingly, showed that this patient had burden of premature ventricular contractions up to 35% of the normal rhythm. This is a short strip from the patient showing that this patient had a frequently bigeminal rhythm. Very important to mention again that this patient denies any palpitation. So what shall I do with this patient? Shall I proceed for ICD implantation because she was diagnosed to have non-ischemic cardiomyopathy? Shall I wait for 9 months on optimal medical therapy or up to 9 months on optimal medical therapy? That's saying that this patient might recover. Shall I start amiodarone for these frequent PVCs because I can't start any other antiarrhythmic medication, or refer her for EP study? So it is known historically that PVCs are benign, and this was the first recorded description of premature ventricular contractions 2,600 years ago from a Chinese doctor when he said, describe it as intermittent perturbations interrupting the normal pulse. And for this long period of time, we know almost the same. When these irregularities did not interfere with normal life, these irregularities did not interfere with normal lifespan when they were occasional. An ominous prognosis was implied if they were frequent. So usually we know that PVCs were not associated with significant risk of sudden cardiac death. Many trials looked at that, and this is one of the important longitudinal study follow-up for about 10 years for 71 patients. Many of these patients had really frequent PVCs, and the conclusion were The long-term prognosis of these asymptomatic healthy subjects with a frequent and complex ventricular ectopy is similar to the healthy US population and suggests no increased risk of sudden cardiac death. Another study from Europe, from Italy, when they followed 61 patients with certain PVC morphology, right ventricle PVCs, for up to 20 years, trying to find out if these patients developed ARVC or anything happened. Interestingly, these are the findings, that no patient died from sudden cardiac death, no patient developed ARVC, 2/3 of these patients were asymptomatic, and importantly, in half of the patient, ectopy disappeared completely. Now, is it benign? It is benign from the arrhythmic point of view, but there are some effects of these PVCs on the heart. Regarding the mechanical function of the heart, if we have a PVC, this has been studied long time ago in the 1980s. And as you see in dogs, this is the end diastolic. This is a two-dimensional echocardiography showing the end diastolic area and the end systolic area. And these are 12 consecutive beats showing almost normal ejection fraction. But when we introduced a premature ventricular contraction at a cycle length of 600 milliseconds, coupling interval 600 milliseconds, we mean by the coupling interval the time from the onset of the normal sinus conducted beat to the onset of the premature beat, which is considered here is long coupling interval. The regular sinus rhythm beat is associated with normal ejection fraction, while the PVC itself is associated with significant drop in the ejection fraction. Interestingly, you notice here that in the post-extrasystole, there is augmentation of the ejection fraction of that beat. When we introduce the shorter coupling interval PVC, the PVC ejection fraction dropped significantly to 15%. More interesting is that the post-extrasystole, they have significantly augmentation of the ejection fraction. Now, that was the mechanical effect. Is this reflected in hemodynamic effect? The answer simply is yes, because after a 600 milliseconds PVC, we see up to 11% drop in the systolic blood pressure. That means it's associated with some hemodynamic effect. What if we introduced a shorter coupling interval PVC? You can see there is up to 60% drop in the systolic blood pressure. So there must be significant consequences for that. So if we have a patient with frequent short coupling interval PVCs or bigeminy, then there is relative bradycardia, because simply the pulse will be halved. It will be 50% of the palpation pulse. For that reason, when patients come to us from home and they have blood pressure monitoring machines, they say, well, the device mentioned that my pulse is 35 or 40 or 50. This is because of the frequent PVCs. Now, there is mechanical effect, there is hemodynamic effect, but is there a risk of LV dysfunction from these PVCs? In 2009, in Heart Journal, there was a very important study that published following up patients for up to 6 years. 240 patients, clinically none of these patients developed any serious cardiac event. But when they looked at the ejection fraction or the LV function for these patients, those patients with high burden of PVCs, they have significant drop in the ejection fraction compared to those who have very little or moderate PVC burden. And that was not the only finding. It was associated with progressive dilatation of the heart, because the left ventricle in diastolic diameter increased. But important to notice that these patients, despite a drop in their ejection fraction, it was still within the normal limits. And this follow-up was only done for 6 years. These are the 13 individuals who had high burden of PVCs. And as you can see here, it is a progressive disease associated with a progressive decline in the LV function and progressive dilatation of the heart. But those who have high burden PVCs and they have normal ejection fraction, was it really normal if we say normal ejection fraction? In 2010, another study was published and showing that when they studied the mechanical function of the heart using the two-dimensional spicklet tracking strain analysis, they found that these patients have significant abnormality in the PVC group compared to the controls. So normal ejection fraction does not mean that there is normal function of the heart. This was replicated or repeated in animal models by Dr. Mark Wood from Virginia and his group. And I think this was one of his last papers. They implanted pacemakers, certain pacemakers that can be programmed to give bigeminal rhythm for 13 dogs, and they followed these dogs for up to 12 weeks. Those dogs who were implanted the pacemaker, they found they have significant drop of their ejection fraction from 60% at baseline to 40%. These are the curves of the dogs who were paced, and as you can see here, excuse me, there was significant drop in the ejection fraction, while the control group, there was no change. Most importantly, when they stopped the pacing, there was a quick recovery of the myocardium and the LV function. When they did autopsy for these dogs, they found no significant structural changes. Later on, another study by Dr. Wang and his group, just recently published, showed that there was some functional changes. And these functional changes were associated with significant dispersion in the action potential. And this significant change in the action potential, we know that it was associated with increased risk of arrhythmia. There were some minor changes or abnormalities in the structure, and the most important are the functional changes. So we have noticed that there is induction of cardiomyopathy by frequent PVCs, but is it reversible or non-reversible? When they stopped pacing in dogs, it was associated with, excuse me, it was associated with improvement after stopping the pacing. But in a human, is this reversible or not? This was the first description of reversibility of PVC-induced cardiomyopathy, which was published from Mayo Clinic group when they followed up 14 patients with frequent PVCs. Their ejection fraction was less than 40% with one antiarrhythmic medication treated. 5 patients had significant suppression of the PVCs, and this was associated with significant improvement in the functional class of these patients and significant improvement in the ejection fraction. Later on, 1 year later, this was the first description of radiofrequency ablation of the PVCs in man for a 26-year-old female lady, and there was again significant improvement from the baseline, 40% to almost 60%. Later on, many case series, many registries were published and showing clearly that these patients have cardiomyopathy referred for ablation, and they have significant improvement after the successful ablation. This is another registry from Michigan group showing the same. Now, we notice that these patients develop cardiomyopathy because of PVCs. What about patients who have ischemic heart disease and they have frequent PVCs? any reports about that. The same group from Michigan showed that among patients, 15 patients who were referred for ICD implantation or any other reasons, and they have frequent PVC burden up to 20%, compared to the control group, they underwent ablation. And many of these patients, after ablation, they have significant improvement in the ejection fraction. So this improvement in the ejection fraction puts many of these patients out of the indication for ICD implantation. And this is exactly what they did. Those patients who had improvement in the ejection fraction, after the ablation, they did not receive ICDs. The same for the non-ischemic cardiomyopathy patients. Those patients who were diagnosed to have non-ischemic cardiomyopathy without any PVCs, depending on significant scarring on MRI and the history of cardiomyopathy, before any onset or presence of frequent PVCs, they did ablation for them. And the successful group, they have significant improvement in the ejection fraction. And these patients went out of the indication for implantation of an ICD. So when do we ablate or treat these patients? Usually, we send these patients for electrophysiologic study and ablation. If there was a frequent PVCs or there is significant symptoms or it is associated with LV dysfunction, very important to notice that usually we like to have patients with monomorphic PVCs. But even if it was polymorphic, but with dominant one or two morphologies, we take them to the lab for ablation. And very important that many of these PVCs are accessible because they were in the outflow tract. Some of them were not easily accessible. We like the accessible. And of course, if they were associated with ventricular tachycardia, we like to take them to the lab to eliminate these PVCs. Now, what the guidelines tell us to do, this is just recently published from the European Society of Cardiology in the European Heart Journal, saying that if we have patients with RVOT-VT, then sending these patients for ablation is considered as class 1 indication. But if these patients have LVOT-VT and they have been treated with antiarrhythmic medication, mainly 1C agents, and failed, then again it is a class 1. But very important, should be done in experienced centers with the ablation. While in patients with LVOT-VT or aortic cusp epicardial VT, then should be done by experienced operator, and this is a class 2A indication. What is the time course for these patients regarding recovery of the myocardium if they have ablation? This is the only study that looked specifically at this. They did an echocardiogram for these patients at baseline, and then they did an echocardiogram after 1 week, then 1 month, 3 months, 6 months, and up to 1 year. And they noticed that the ejection fraction starting improving after the first week and reached the maximum up to 1 year, and may improve more. And the other structural changes started again from the first week after the ablation. Back to our patient. This patient, she was sent to the EP lab. Successful ablation was done on October 13, 2015 in the RVOT. Echo was done next day of the procedure. Surprisingly, there was significant improvement in the ejection fraction for this patient. Despite we know it starts after 1 week, but no one looked at the second day of the procedure. We did it actually because it was a complex procedure to rule out if there is pericardial effusion. So we did a full study before discharge, and we found this significant improvement in the ejection fraction. Now, 24-hour Holter monitor was done for the patient at 6 weeks and showed less than 1% PVC burden, none of them from the outflow tract. 3 months echo is pending. So to take home message, persistent bigeminy is associated with significant symptoms because it halves the pulse rate. high burden of PVCs is associated with reversible form of LV dysfunction. Radiofrequency catheter ablation is an effective therapy for PVC-induced cardiomyopathy. Thank you very much.
Thank you very